Greetings. My name is Dr. Connie Celum, and I'm a professor of global health medicine epidemiology at the University of Washington. And it is my great pleasure to welcome you to what it promises to be a fabulous webinar on syphilis. And I love the name, Syphilis Resurgent. Unfortunately, it is resurgent. And you will hear from Dr. Jason Zucker, who will be talking about the how to address the growing epidemic from prevention to perinatal impact. It's going to be a very full hour. There's so much one can say about syphilis, and he is an expert in this area and has put together a great talk. So I welcome you all. Please do answer the demographic questions. It helps us know who our audience is. Next slide. And just want to thank the web board who have helped to vet topics and speakers, and these are their financial relationships within the last 2 years. Dr. Zucker reports no relevant financial relationships, and I report that I have served as a scientific advisor to Merck. And then we've had 2 planners and reviewers who have no financial relationships. There are continuing education credits available, which you can find out how to claim credit on the website, IAS-USA.org. Want to really thank our platinum supporters, Gilead, Merck, and ViiV, and just really appreciate their support for this and other IAS-USA activities. So just before we get started, wanted you to know that I think there are a couple of poll questions within Dr. Zucker's presentation. So we'll show you the responses after the poll closes. We really want this to be interactive. Syphilis is challenging for all of us. No matter how many cases we see, we continue to learn more. So please do submit questions, and please use the Q&A button, not the chat function. We'll do our very best to answer as many as we can. And I love the fact that we have a very diverse audience. This will be fun. Please, when you do submit a question, include your full name and institution through the Q&A and not the chat function. So now it's my pleasure to introduce Dr. Jason Zucker, who is an assistant professor of medicine in the Division of Infectious Diseases at Columbia University and is also an assistant medical director at the New York City STD Prevention Training Center. He trained as a combined adult and pediatric ID physician and provides status-neutral, HIV status-neutral sexual health care to patients of all ages. And his research focuses on ways to optimize engagement in the sexual health cascade of care. So Jason, take it away, and I'm going to go off screen and look forward to hearing your presentation. Thank you.
Awesome. Thank you so much, and thank you so much for all your help. So good afternoon, and thanks everybody in IAS-USA for inviting me. It's really a privilege to get to speak with you today about one of many ID doctors' favorite topics, which is syphilis. We did the financial disclosures, and the learning objectives for today are here. We'll start with the first pre-test question. A 32-year-old man presents to care with a single painless ulcer on the ventral shaft of the penis. He does not have a prior rapid plasma reagent test result, and he reports recent condomless sex with a new partner. Which of the following is the most appropriate treatment? Benzene penicillin G 2.4 million units IM in a single dose, doxycycline 100 milligrams twice daily for 7 days, benzene penicillin G 2.4 million units IM weekly for 3 weeks, or wait for the RPR test results before initiating any treatment. All right, we'll go on to the next question now. Which of the following statements is true about doxycycline post-exposure prophylaxis based on current evidence? Doxypep has been shown to induce resistance in Treponema pallidum. Doxypep has been shown to reduce syphilis infections among men who have sex with women and women who have sex with men in clinical trials. Doxypep reduces syphilis incidence and has not been associated with increased resistance in the real world. And doxypep is only effective when taken daily as a preventive measure. All right, and we will come back to these questions at the end. So before I dive into the meat of today's presentation, I always think it's important to highlight the fact that it didn't have to be this way. In 1999, there was a national goal to reduce primary and secondary syphilis cases to 1,000 or fewer and increase the number of syphilis-free counties in the United States to 90% by 2005. And the words they said back in 1999 hold true 26 years later. As we approach the end of the 20th century, the United States is faced with a unique opportunity to eliminate syphilis within its borders. Syphilis is easy to detect and cure, given adequate access to and utilization of care. And elimination of syphilis would have far-reaching public health implications, removing two devastating consequences of the disease: increased likelihood of HIV transmission and compromised ability to have healthy babies. However, this is what we actually are living in now. This is the 2023 state of the STIs in the United States. And while we've made some progress with gonorrhea and chlamydia cases decreasing over the past 5 years, instead of 1,000 or fewer cases, we have over 209,000 cases of syphilis, a 61% increase in the past 5 years. And even worse, we have almost 4,000 cases of congenital syphilis per year, a staggering 106% increase in the past 5 years, and a tenfold increase in the past decade. And syphilis is increasing rapidly, as you can tell from those numbers. The chart on the left shows reported cases of syphilis by stage of infection from 1941 through 2023. And I placed a blue arrow over the peak from 1990 and a green arrow over our current day. And as you can see, we're not so far away from that peak. This second chart shows the same data from the past decade, so you can better see the dramatic rise in cases of total syphilis over the past 10 years. And this is not just a single person problem. Syphilis is affecting everybody. In fact, syphilis rates, while increasing in men, are actually increasing more rapidly in women than in men. The male to female ratio, which is the pink line here, is decreasing because the rate of syphilis in females is increasing faster than that of men. This surge in women, particularly of those of childbearing age, is what's driving this dramatic rise in congenital syphilis cases. As you can see, as cases of congenital syphilis as cases of primary and secondary syphilis increase among pregnant women, you're seeing an increase in cases of congenital syphilis. And syphilis cases are not in any one geographic regions. When we look at the guidelines for screening, we'll see that they refer to high prevalence areas. Previously, it wasn't clear what a high prevalence area was, but in this article, the CDC defined high prevalence as greater than 4.6 cases per 100,000 women. The counties in green that you see on this map are considered high prevalence areas with rates of syphilis that necessitate increased screening. What they found is that while 38% of US counties were high prevalence, these counties comprised over 72% of the US population. And so it's likely that wherever you are listening to this, you're in what would be considered a high prevalence area and need to be thinking about screening for syphilis. These are the current CDC screening recommendations for syphilis. And you can see that for some groups, for example, men who have sex with men, they recommend annual screening with increased screening for those deemed at risk. What does at risk mean? Well, per the CDC guidelines, this includes specifically men who have sex with men under the age of 29, incarcerated populations, individuals engaged in transactional sex work, and individuals in high prevalence areas, which, as we just discussed, is a majority of the US population. Keep in mind that these are narrow definitions that don't take into account many aspects of someone's life. And if we ever want to reduce the rising rates of syphilis, we need to increase our screening. And as I mentioned before, local epidemiology and communities with increased prevalence make up 72% of the US population. Now I want to start by introducing a case based on a patient who actually was seen relatively recently by us. This patient, we'll call him Jim, is a 41-year-old man. He identifies as gay, is not currently monogamous, and currently has multiple male partners on the weekends. He actually has a history of rectal cancer young, status post resection and chemotherapy in remission. He presented to his GI doctor with complaints of rectal pain because he was concerned about a recurrence of the cancer. And so the question I want to start with today is, could this rectal pain be syphilis? Now, lots of what we talk about today will be based on the stages of syphilis. And so while many of you may know them already, it's crucial that we're all on the same page. Syphilis progresses through several distinct stages. After exposure is an incubation period that can last up to 90 days, during which time patients may have no symptoms and lab testing may be negative. This is one of the reasons we recommend presumptive treatment for sexual contacts rather than a test and treat approach because of this prolonged incubation period. After incubation is primary syphilis. Primary syphilis is defined by local symptoms, traditionally the painless chancre that we think of as classic for syphilis, that occurs at the site of inoculation. It's really important that we think of them as being painless because if a lesion doesn't hurt, people may not notice it. So if the chancre is in an unusual place or a place that's not easily seen, for example, the rectum, vagina, or oral cavity, patients may have no idea that they have a lesion or ever had a lesion that resolved. As a reminder, syphilis does not have to be on the genitals. Chancres can occur anywhere, including on the tongue, and we've seen them in the throat as well as in the anus very frequently. These ulcers are typically accompanied by lymphadenopathy, typically in the regional nodes and sometimes bilaterally, and this can be a helpful diagnostic clue, especially when the lesion is somewhere that's not easily visualized. Also underscores the value of doing a complete physical exam to help us stage syphilis. Primary syphilis is highly infectious and will resolve on its own in 1 to 6 weeks if untreated. In this case, our patient doesn't have a painless lesion. He has what actually sounds a little bit more like proctitis. So can syphilis cause that? Well, we're seeing more and more atypical presentations of primary syphilis. Instead of the classic single painless ulcer, we frequently see multiple atypical or painful lesions at the site of infection, particularly at the rectum. In addition to painful anogenital lesions, syphilis can also cause proctitis. And it's actually not that rare. In this study from the University of Washington, syphilis was found in about 4% of proctitis cases in a sexual health clinic. So even without a classic chancre, proctitis may be the presenting sign of early syphilis. So going back to our patient, Jim's GI doctor ordered a CAT scan, which showed proctitis with mild lymphadenopathy in the right pelvic region, perirectal area, and inferior mesenteric chain, raising concern for possible cancer with lymph node metastasis. A colonoscopy was rapidly scheduled, which showed a moderately inflamed, nodular, and ulcerated mucosa. So could this be syphilis? Well, the answer is yes, it definitely could be syphilis. There are many case reports that show that syphilitic proctitis can mimic rectal cancer, both clinically and on imaging. These are just a few of the many case reports I found out there that I included here. So when we're evaluating proctitis, we can't forget to consider syphilis. So the colonoscopy was completed as we discussed before, and pathology was pending. And actually pathology was pending for quite a while. After 1 week, pathology returned with syphilitic proctitis with a positive treponema pallidum immunostain confirming the diagnosis. Here on the right is the immunohistochemical stain used to identify spirochetes in the tissue. You can see all these thin brown lesions here. These are the treponema, and they're in the lamina propria and all around the glands. The background shows dense lymphoplasmacytic inflammation, which is a common finding in syphilitic proctitis. There are a lot, as you can see, all these brown squiggles here, a lot of treponemes in this image. In fact, in my discussion with the pathologist, she said it's actually the most spirochetes she's ever seen in one of these path samples. So this really helps clinch the diagnosis, and he has syphilis, or syphilitic proctitis. And this is where the case gets a little funny. Instead of coming to our sexual health clinic, he got sent to the ED for treatment. In the ED, he was noted to have a diffuse rash that spared the hands and feet. And here are some pictures of that rash. Because of the rash, he had some labs done and had abnormal labs, including an elevated RPR to 1 to 256, an elevated creatinine of 1.34 from a baseline of 1, and elevated liver function tests, including an elevated total and direct bilirubin, AST, ALT, and a markedly elevated alkaline phosphatase of 737. So he has a diffuse rash, elevated creatinine, and elevated liver function tests. Could these all be from syphilis? So we talked earlier about primary syphilis, which is generally at the site of inoculation. It's possible that that proctitis was due to primary syphilis. But more likely it may be secondary syphilis, which is really disseminated disease. Secondary syphilis is disseminated infection. Since it's disseminated, it can have lots of symptoms, although most commonly and classically are the dermatologic manifestations, like the rash on the palms and soles, as you can see in these classic CDC pictures on the right. It can also include painless generalized adenopathy, low-grade fevers, and fatigue. However, secondary syphilis can have a whole range of symptoms affecting almost any organ system: skin, mucous membranes, hepatitis, renal symptoms. And this is a table from the New York City PTC monograph that outlines some of the many potential manifestations of secondary syphilis, and I've highlighted the ones that he potentially could have. Secondary syphilis is also highly infectious and generally will resolve around 6 weeks if untreated. Everything we've discussed so far about staging impacts syphilis treatment, which is entirely based on disease stage. This slide outlines the CDC recommended treatments along with alternative options and has been unchanged for years. For incubation, primary, secondary, and early latent syphilis, the standard treatment is a single dose of benzazine penicillin G, or BPG, one time, with an alternative of 100 milligrams twice daily of doxycycline for 14 days. For late syphilis, late latent syphilis of unknown duration, and tertiary syphilis, it's BPG 2.4 million units weekly for 3 weeks, with an alternative regimen of doxycycline 100 milligrams twice daily for 28 days. Finally, for neuroocular or otic syphilis, the recommended regimen is IV penicillin for 10 to 14 days. It's important that we review this because correct staging ensures that patients get the right treatment to prevent complications and reinfection. One other thing I'd like to add is that there used to be an alternative treatment for neuroocular and otic syphilis, which was IM procaine penicillin daily for 10 to 14 days. While operationally challenging because you had to have people come in for 10 to 14 days for IM therapy, it was an option. However, the manufacturer has since discontinued procaine penicillin, and since it's no longer available, it's no longer a viable alternative treatment. So because of his rectal lesions, he was staged as secondary syphilis and given benzazine penicillin G 2.4 million units times 1. He was still in the ED and a few hours later actually developed a fever to 101.5. Because he was in the ED, he was started on vancomycin and piperacillin and tazobactam, and an infectious workup was initiated. So could this fever be syphilis? And hopefully people recognize that this could certainly be from the Jarisch-Hersheimer reaction. The Jarisch-Hersheimer reaction is a transient systemic inflammatory response that occurs after starting antibiotic treatment for spirochete infections like syphilis. It's most commonly seen in early syphilis, especially when there's a high bacterial burden. Reactions generally begin 2 to 12 hours after the first dose of therapy, and most patients recover within 24 hours. Symptoms can include things like fevers, chills, myalgias, headaches, tachycardia, hypotension, and worsening of existing lesions. It is important that this is not an allergic reaction, and so there's no need to stop an antibiotic if you're getting IV therapy, and you don't need to list patients as having an allergy to penicillin in their charts. And this reaction is very common. In this very recent study, investigators actually looked at a secondary analysis of a multi-center phase 4 randomized controlled trial. They had 249 adults with early syphilis treated with BPG and looked for the Jarisch-Hersheimer reaction within 7 days post-treatment. What they found is that almost 24% of patients experienced symptoms, with a median onset of 4.9 hours and a median duration of 12.8 hours. And it was about 3 times more likely in secondary syphilis. The most common symptoms included myalgias, chills, weakness, and fevers. And so clearly his fever in the ED after treatment for syphilis can certainly be due to the Jarisch-Hersheimer reaction. So the rectal pain, the rash, the fever are all likely related to his syphilis. But what about his abnormal kidney and liver function tests? Well, these got worked up extensively. In fact, for his kidneys, he actually got a kidney biopsy and a diagnosis of membranous nephropathy with a negative spirochete immunostain. For his liver, he underwent an extensive infectious and autoimmune workup that was unrevealing, and an MRCP showed a normal liver without suspicious lesions, no evidence of cholangitis, and no evidence of metastatic disease. So let's talk more specifically about these two findings. So he underwent this kidney biopsy, which showed membranous nephropathy, and I intentionally left out the part of the path report that said that syphilis is known to be associated with membranous nephropathy, although additional consideration should be clinically excluded. This is important because membranous nephropathy is actually the most common kidney pathology associated with syphilis. In this recent retrospective cohort study, they looked at 102 patients with active syphilis who underwent kidney biopsies, and they found membranous nephropathy was the most common, seen in about 28.4% of patients, acute tubular injury at 23.5%, and HIV-associated nephropathy in 20.6%. This tells us that kidney disease in the setting of syphilis can mimic a variety of pathologies, with membranous nephropathy being the most common. And if we find membranous nephropathy, we do need to think about syphilis in the right context. The good news is that treatment with penicillin is often effective and may lead to reversal of the kidney disease. Now is abnormal liver function tests. So in the context of syphilis, he was found to have elevated liver enzymes, particularly an alkaline phosphatase greater than 700. And this pattern is very consistent with what's been described as syphilitic hepatitis. Histopathologically, syphilitic hepatitis can show bile duct inflammation and even granuloma formation, although liver biopsy is rarely performed and was not performed in this case. Importantly, imaging studies like MRCP can often appear normal even in the presence of liver involvement. They developed a proposed diagnostic criteria for acute syphilitic hepatitis that includes abnormal liver enzymes suggesting hepatic involvement, which we had in this case, serological evidence for syphilis with an acute clinical presentation consistent with secondary syphilis, which we had in this case, exclusion of alternative causes of hepatic injury, which was well worked up, and improvements in liver enzymes with appropriate antimicrobial therapy, which is what happened here as well. This patient certainly met all the criteria for a diagnosis of syphilitic hepatitis. And so the final diagnosis for all of Jim's issues is likely secondary syphilis. I do like to remind people that the proctitis we think is secondary syphilis, but could be primary, especially if there was a chancre there. And some patients do have overlap of primary and secondary syphilis. Because he had secondary syphilis, his one dose of penicillin was likely adequate treatment. So that's all for Jim for now, but let's meet another patient, this time Jack. Jack is a 29-year-old bisexual cisgender man with well-controlled HIV. He's been a patient in the clinic for several years and takes daily bictegravir, emtricitabine, tenofovir, alfenamide. He has one long-term primary female partner and multiple male partners on the weekends. His last visit was 3 months ago, and he came in for quarterly STI testing as part of his HIV prevention program. Jack has no symptoms, and so in clinic we do an exam, which is unremarkable, and send off our usual quarterly labs. This includes HIV antibody antigen testing and HIV qualitative NAT as per the HIV prevention guidelines, 3-site gonorrhea chlamydia testing, and an RPR for syphilis testing. And his labs returned negative for HIV, negative for gonorrhea and chlamydia, but with an RPR of 1 to 512, up from 1 to 4 just 3 months prior. So because he's asymptomatic, this is our opportunity to talk about latent syphilis. Latent syphilis is the stage of infection where people have no symptoms, no clinical signs of primary, secondary, or tertiary syphilis. Latent syphilis is then further classified by the duration of infection. Early latent syphilis refers to an infection acquired within the last 12 months, while late latent syphilis suggests the infection is more than a year old. If you're unable to determine when the infection began, then it's considered latent syphilis of unknown duration. And this classification has important implications for treatment that we looked at a little bit earlier, and we'll look at again shortly. I'll say this many, many times, but if symptoms are present, it's not latent syphilis. It doesn't matter what previous test results show or how long ago the person was tested or treated. The presence of symptoms always pushes the diagnosis into an active stage. So syphilis testing is most beneficial for those without clear signs. And frequent screening really is the key to reversing trends, especially for identifying those people with early latent syphilis who might still be very contagious. For that, there are two screening algorithms that are commonly used. The traditional algorithm starts with a quantitative non-treponemal test, most commonly the RPR. If reactive, it goes to confirmatory testing with a direct treponemal test, like an FTA antibody or a TPPA antibody. And the thing to remember is that a positive treponemal test indicates either active infection or prior treated infection. And it's the quantitative titers that we'll look at on the next slide that help us distinguish from active from treated infection. Conversely, the reverse screening algorithm starts with a direct treponemal test, usually an EIA or CIA. If positive, it reflexes to the quantitative non-treponemal test. And if you have discrepant results, a second direct treponemal test is used to clarify the diagnosis. Once again, evidence of syphilis infection means that there's either an active current infection or a prior treated infection, and we really need to be able to interpret titers because it's key to both screening algorithms to assess treatment response, as well as to look for reinfection. So this is an example of the RPR card. The RPR card works by mixing serum with charcoal label antigens, and if antibodies are present, they cause visible clumping, indicating a reactive result. As you can imagine from something like this, it really is very operator dependent. And titers get reported as dilution, so 1 to 2, 1 to 4, 1 to 8, 1 to 16. Because of some variability in the test, it's a 4-fold change or a 2 dilution change that's clinically significant for reinfection or treatment failure. Titers typically decline after treatment, but some patients do remain serofast with persistent low-level titers despite adequate treatment. One other thing worth noting is that very high antibody levels can cause false negative results due to the prozone effect, where excess antibodies interfere with proper proper formation in these cards. Diluting the specimen can help make the diagnosis. Now, because we have two different testing algorithms, I get a lot of questions about which algorithm one should choose. In general, that makes me smile because realistically, most of us only have access to the algorithm at their institution, but it is important that we understand both algorithms, recognize their pros and cons, and also recognize that the CDC says either one is acceptable. The traditional algorithm is cost-effective. RPR tests are inexpensive and quick. They allow for tighter monitoring quickly and are widely understood. But the first step of the RPR is manual, so while the test itself is cost-effective, personnel costs can get high with a high volume of tests. It can also miss early infections because it has a lower sensitivity in the early as well as the late stages. In the reverse algorithm, the first test is automated, which makes it very cost-effective for labs that perform a large volume of tests. It's also better at detecting early infections and may catch cases that RPR only would have missed, but it is more expensive upfront, requiring a machine. It requires more complex interpretation that many providers are not familiar with. And again, the direct treponemal tests frequently are positive for life, meaning these initial tests may be less helpful in high prevalence populations where you really need the RPR to interpret. We didn't use them in this patient's case, but there are two other tests I want you to be aware of. On the left is point of care serologic testing for syphilis. Point of care tests have sensitivities ranging from 50 to 99%. And these tests are FDA cleared and CLIA waived, making them really useful in settings like the emergency department, urgent care, and field-based screening. On the right, we have something new and exciting as well. Last August, so just about a year ago, the FDA authorized the first over-the-counter at-home syphilis test in the US. This test detects treponema pallidum antibodies from a finger prick blood sample, giving results in 15 minutes with a sensitivity of 93% and specificity of 99.5%. Both of these tests really have the potential to provide rapid results, to reduce the time to treatment, especially for populations unlikely to come into clinic for testing or unlikely to come back for follow-up after blood is drawn. However, both of these home tests are treponema-based, which can remain positive for life. They can't distinguish between active from previously treated infections, and so they do require additional testing. The point of care testing actually resembles the reverse sequence algorithm. As I said, starting with a direct treponemal test, followed by a non-treponemal test that's frequently done in the laboratory to confirm and guide management. Point of care testing is especially useful in patients without a known history of syphilis and in community settings such as in testing events, urgent care EDs, and many places even provide empiric treatment in individuals who are vulnerable to syphilis with a reactive result and no prior syphilis testing. I do want to highlight one other form of testing, which is becoming more rapidly available, and that's molecular testing for syphilis. Molecular testing detects treponema pallidum DNA from lesion exudates, tissue, or body fluids. It's most useful in primary syphilis, particularly when ulcers are present, you can get a swab of the lesion. Sensitivity really varies by sample type and ulcer stage, and it's much less sensitive in secondary syphilis than primary. While there are no FDA-approved assays available, there are lab-developed tests that are commercially available at the major commercial labs. Some of the advantages are they can confirm syphilis prior to seroconversions, and they can also help differentiate treponema pallidum from other genital ulcer diseases like HSV or chancroid or mpox. Some of the limitations, though, are they don't rule out syphilis, especially in later stages, but they're certainly valuable to know about. And back to our treatment slide again. In the case of Jack, we're thinking about him having early latent syphilis, and so we're thinking about him receiving treatment with a single dose of BPG. And so Jack was diagnosed with early latent syphilis and recommended to receive BPG. What he then said, though, was that he's really sorry. I did that shot 3 years ago, and it's just too painful. I can't do it again. He then added, I also can't take doxycycline. Last time I took it for chlamydia, I threw up everywhere. So we tried some shared decision making, and he really ended with, let me think about it overnight. I'll come back tomorrow. So he left and said he'd come back tomorrow. And while he did, I looked into some alternative treatments for him. So whenever I talk about syphilis, we really get a lot of questions about alternative treatment options, whether it's due to penicillin allergies, the benzazine penicillin shortage that we had over 2 years, a year ago, and other concerns people have. They're always looking for other options. While there are many things that could be considered, there are 5 that I look at first when it comes to syphilis. The first is azithromycin. Azithromycin has been considered an alternative treatment for syphilis and was even in previous iterations of the STI treatment guidelines. Azithromycin is appealing since it's an oral once daily dosing and even safe in pregnancy. However, resistance to macrolides, including azithromycin, is widespread. A recent New England Journal article highlighted near universal resistance in North America, and because of this, azithromycin is specifically not recommended for syphilis treatment. Next up is linezolid. Linezolid has also been considered as a potential alternative. It's another oral option which is appealing and has excellent CNS penetration. However, a recent study evaluating linezolid at 600 milligrams daily for 5 days found that it did not meet non-inferiority criteria compared to benzazine penicillin G, meaning we should not be using it for early syphilis treatment. With that said, it's still an open question whether that was the right dosing regimen, and there's ongoing research into whether twice daily dosing might yield better results. The third treatment option I want to highlight is amoxicillin, which has been studied as an alternative regimen for syphilis, often paired with probenecid to boost serum levels. One notable context is in Japan, where until recently BPG was not available, and amoxicillin-based regimens were routinely used. Japan actually published a randomized controlled trial comparing amoxicillin plus probenecid to amoxicillin alone and demonstrated high rates of serologic cure, 90.6% with low-dose amoxicillin, 94.4% with amoxicillin plus probenecid. However, they did not compare amoxicillin to BPG. So we really do lack comparative data about how amoxicillin compares to what is the standard of care in this country. Next up is cefixime, an oral third-generation cephalosporin. In a small two-arm non-comparative pilot study, the treatment success rate in the cefixime arm was 87%, with a 95% confidence interval of 69 to 100%, so single-arm study. This was a very limited study, and because of that, cefixime is not currently recommended as standard of care for syphilis. With that said, there's an ongoing study in Brazil, led by the CDC and WHO, that is investigating cefixime in men who have sex with men. Although the current status of that trial is not yet clear, they were enrolling as of several months ago. And so hopefully we'll see more data about the potential use of cefixime in treating syphilis in the near future. The final option we'll cover is ceftriaxone, which I've already seen a few questions about in the question and answer section. Ceftriaxone is a third-generation cephalosporin that's available IV and IM. It is recommended as an alternative treatment by the WHO, and that recommendation is really based on limited supportive data, but it can and has been used when penicillin is unavailable or contraindicated. Unlike benzodiazepine penicillin, ceftriaxone has a much shorter half-life, which requires daily IV or IM administration. Suggested regimens include 10 days of ceftriaxone for early syphilis, 10 to 14 days for neuroocular otic syphilis. The problem with ceftriaxone is while it looks appealing, we don't have any good clinical trials comparing it to BPG. Dosing and duration are not fully standardized. And so while it remains an alternative, it's really an alternative for when BPG is not available. Going back to our patient Jack, who unfortunately did not return the next day as advised. About 1 month later, he noticed he was having a hard time hearing the TV. He went to an unaffiliated emergency department near his house, where he was seen by the ENT doctor, who diagnosed him with asymmetric hearing loss and recommended an MRI. The MRI was unremarkable, and he was advised to follow up outpatient. 2 months after that, he went back to the same ED, this time because he was having difficulty seeing the TV. I should probably mention that this was early in COVID, and he was probably spending a lot of time at home watching TV. He was evaluated at that time by ophthalmology and diagnosed with panuveitis. They recommended sending a full panuveitis workup. From an ID standpoint, I know that includes both RPRs and quantiferon golds, and told him to follow up outpatient. So the question now is, could all this be syphilis? Could the hearing and vision changes be syphilis? And as you've probably guessed by now, the answer to everything today is probably yes. I want to highlight that neuroocular and otic syphilis are not just late complications. They can actually occur at any stage of syphilis, including early infection. These manifestations can present with or without other signs of syphilis, which makes them really easy to miss if we're not actively looking for them. As the total number of syphilis cases increase, we are seeing a rise in these serious complications, including permanent vision and hearing loss that can be irreversible if treatment's delayed. Ocular syphilis often presents as panuveitis, but it can actually involve any part of the eye, including the conjunctiva, anterior chamber, cornea, optic nerve, and retina. Otosyphilis typically presents with cochleovestibular symptoms, things like tinnitus, vertigo, and central neural hearing loss that can be either unilateral or bilateral, can have a sudden onset, or can progress rapidly. Both of these things really are medical emergencies. If not recognized and treated promptly, they can lead to permanent vision and hearing loss. And that's why I wanted to highlight them today, just because it's so important to maintain a high index of suspicion for these symptoms. Kings County has developed a really practical screening questionnaire for neurosyphilis, which we routinely use in our clinic, and includes targeted questions to screen for otosyphilis, ocular syphilis, and neurosyphilis. This is quick and easy and helps ensure we're not missing this potentially serious complication in our patients. Whenever we talk about otic syphilis and optic syphilis, we get a lot of questions about lumbar punctures. So does Jack need an LP? The answer is no, not automatically. The 2021 CDC STI treatment guidelines actually updated this section to make the use of lumbar puncture more selective, because serum RPR is sufficient for monitoring treatment response in most cases. An LP is really only indicated when patients have neurological signs or symptoms that are not auditory or visual. For tertiary syphilis, For asymptomatic patients with a fourfold titer increase after appropriate therapy, and for patients with high titers that fail to decrease fourfold without a clear risk of reinfection. In most cases, we no longer need a lumbar puncture for these patients, although they still do need treatment with IV penicillin, 18 to 24 million units per day, over 10 to 14 days. In terms of alternative treatments, I tend to personally avoid alternative treatments for these symptoms. Because it can lead to permanent hearing and vision loss, I prefer to use penicillin whenever I can. If there's some reason that penicillin cannot be used, ceftriaxone is a potential alternative. The typical dose is 1 to 2 grams daily for 10 to 14 days. And while not nearly as extensively studied as penicillin, retrospective data suggests good efficacy. If both penicillin and ceftriaxone are not viable options, doxycycline can be considered. In this case, the recommended dose is 200 milligrams twice daily for 28 days. But it's important that patients are aware that the evidence is really limited, especially regarding long-term outcomes. Again, these alternatives may be useful in select cases, but should be approached cautiously and close clinical and follow-up as needed. Now, I did want to highlight for a moment the fact that Jack is living with HIV and what that means for his syphilis management. First is that testing is the same in both groups. Treponemal and non-treponemal tests are interpreted the same way regardless of HIV status. For treatment, the standard therapy applies to both groups. There are no changes in treatment based on his HIV status. When it comes to titer response, we may see a difference. In people with HIV, the decline in RPR titers can be slower, and it may take longer to see that fourfold drop we typically look for. The risk of neurosyphilis is also higher in people with HIV, so screening and asking those questions becomes really important. So back to Jack. So Jack actually called me after his ophthalmology visit and told me everything was going on. We talked about potential options, and Jack actually had a midline catheter placed at home and completed 14 days of IV penicillin. After we talked about placing the line and getting the penicillin, he asked, when should I come back to get tested again? So RPR follow-up depends on syphilis stage and HIV status. For patients without HIV, we check the RPR at 6 and 12 months, with a fourfold decline expected by 6 to 12 months for early stages, and 12 to 24 months for later stages. For HIV positive patients, we follow more closely at 3, 6, 9, and 12 months for early syphilis. And for late latent, we follow patients at 6, 12, and 24 months, and really think about additional testing if titers plateau. So I left one part of the story out. When Jack was first diagnosed, we talked about making sure his female partner got tested. But after Jack and I discussed the plan to place the line and when he needed to follow up, I was just about to sign off the video visit, and he mentioned just one more thing to me. Oh, just one more thing. What about my female partner, Jill? She's 16 weeks pregnant. So, as I said, we talked about Jill needing treatment before, but he never mentioned to me that she was pregnant. So let's meet Jill. Jill's a 28-year-old woman and is Jack's long-term primary partner. She's actually been a patient in our clinic with another provider for several years and takes TDF-FTC for HIV prevention. She's currently 16 weeks pregnant and has no symptoms. And so this is really our opportunity to talk a little bit about congenital syphilis that I mentioned early on is rising very rapidly. So why are congenital syphilis cases rising? Well, as with many public health challenges, it's multifactorial, but this study really highlights some key gaps. 40% of patients with congenital syphilis didn't have adequate treatment. 37% received no timely test, and 11% were diagnosed and had no treatment at all. This really demonstrates that about 88% of these cases, there's an opportunity for us as providers to intervene. We can ensure people get adequate treatment, we can ensure they get tested, and we can ensure that if they're diagnosed, they get treated appropriately as well. Assessing for congenital syphilis can be challenging because it requires evaluating both the mother and the baby. It's also challenging because non-treponemal and treponemal antibodies can cross the placenta, making serologic testing difficult to interpret. In terms of assessing for congenital syphilis, there are generally 4 steps. We want to identify syphilis in the mother, determine if maternal treatment was adequate, look for the presence of clinical lab or radiographic evidence of syphilis in the neonate, and compare maternal and neonatal non-treponemal serologic titers. So as I said, the first step is to identify syphilis in the mother, and syphilis in testing in pregnancy follows the same principles as in non-pregnant patients. The one caveat is that false positives are more common, and positive low titer non-treponemal tests may be transient false positive of pregnancy if the confirmatory test is negative and the patient is asymptomatic and does not seem particularly vulnerable to infection. If patients are RPR positive but confirmatory testing negative and not at risk, repeating the RPR is generally not helpful, as false positives can persist for up to 6 months. We do always recommend that these patients have follow-up evaluations after delivery to ensure an accurate diagnosis. So Jill saw my colleague in clinic. Her physical exam was unremarkable. She got our standard testing and was empirically treated with BPG ×1 given her exposure. The next day, her results returned with an RPR of 1 to 16. She had been 1 to 1 at her previous visit about 6 months ago. And so the question for Jill is, was one injection of BPG enough in pregnancy? So treatment in syphilis in pregnancy is largely the same as in non-pregnant individuals. The biggest difference is that we have no alternative options. Penicillin is the only recommended treatment. And for patients with a penicillin allergy, desensitization is required, as doxy is currently contraindicated in pregnancy. Otherwise, everything else is the same with 2 notable caveats. First is additional therapy. There's some evidence that additional therapy can help prevent congenital syphilis in pregnant patients. For primary, secondary, or early latent syphilis, a second dose of BPG can be given 1 week after the initial dose to enhance treatment effectiveness. The second difference is in timing between missed doses. For non-pregnant persons, clinical experience suggests that 10 to 14 days between doses is probably okay, although 7 to 9 days is preferred. For late latent syphilis in pregnancy, missed doses matter more. If it's greater than or equal to, and I apologize because the underline you can't see the equal to, greater than or equal to 9 days between doses, it's not acceptable for pregnant women, and they should restart the full course of therapy. In terms of retreatment and assessing, it's really challenging in pregnancy. And the reason for that is that, we don't expect people to have their titers resolved for 6 to 12 months, and pregnancy is only 9 months long. And so in general, we recommend that if people are diagnosed before 24 weeks of gestational age, we repeat the RPR after 8 weeks, we repeat it at delivery, and titers should be repeated sooner if reinfection or treatment failure is suspected. For patients diagnosed or treated after 24 weeks gestation, we just recommend repeat at delivery. I will note that some jurisdictions and providers perform monthly testing for pregnant women treated for syphilis to look for reinfection, although that's not a formal recommendation. But we should consider more frequent screening if clinically indicated. For example, a partner declines treatment, which happens more than we'd like, or they're sexually active with new partners. So going back to Jill, Jill has an otherwise uncomplicated pregnancy and gives birth to a healthy baby at 39 plus 3 weeks gestation. She was retested monthly, and her RPR titer at delivery was 1 to 2. So in this case, we already know that mom had syphilis and was adequately treated. But what about the baby? And that's where 3 and 4 come in. I'll say that the pathophysiology of congenital syphilis is fascinating. Spirochetes actually cross the placenta, enter fetal circulation, and disseminate to virtually all organs. What we see clinically isn't the presence of bacteria, but it's the fetal inflammatory response that happens at around 20 weeks gestation, which leads to this multi-system involvement. This illustration from the New England Journal highlights just how widespread the manifestations can be with skin, liver, CNS, bone, eyes, lungs, and more. Because any organ is involved, a thorough exam and workup is essential for an accurate diagnosis. So in addition to clinical signs and symptoms, lab findings can be helpful for diagnosing congenital syphilis. These can include subtle findings such as anemia, thrombocytopenia, leukopenia, or leukocytosis, as well as more clear findings such as CSF abnormalities like elevated white blood cell count in the CSF, elevated protein in the CSF, or a reactive CSF VDRL, which is highly suggestive of neurosyphilis. Finally, radiographic findings can be both suggestive and pathognomonic for congenital syphilis. Things like periostitis with irregular periosteal thickening, metaphyseal serration, and demineralization and destruction of the upper medial tibia. Finally, the last part of assessing for congenital syphilis is comparing maternal and neonatal non-treponemal titers. This should be done using a neonatal serum RPR, not cord blood, so as maternal antibodies can't lead to misleading results. And again, you're looking for that fourfold change. A fourfold increase in neonatal titers compared to maternal titers is diagnostic of congenital syphilis. However, diagnosing congenital syphilis is not easy. It requires all the information we just discussed in these 4 categories, and then we can put them into one of 4 scenarios: proven or highly probable, possible, less likely or unlikely. And each of these categories helps us decide what evaluation and treatment is needed to ensure the best outcomes for the infant. In the interest of time, I'll go through these relatively quickly, but we have diagnostic criteria for each category. Proven or highly probable is the clearest. These include physical exams that are consistent with congenital syphilis, a serum quantitative non-treponemal titer greater than 4-fold the maternal titer, or evidence of direct detection of treponema pallidum on either dark field microscopy or via PCR. This can be from a skin lesion, from nasal discharge or snuffles, or from the placenta itself. Possible, less likely, and unlikely all have normal physical exams and serum quantitative titers that are less than or equal to 4-fold maternal titer. In the possible criteria, the mom had inadequate or undocumented treatment or was treated less than 4 weeks before delivery. In the less likely criteria, mom received appropriate treatment during pregnancy and it was greater than 4 weeks before delivery, and there are no signs of reinfection or relapse. And unlikely criteria, the mother was adequately treated before pregnancy with low stable titers throughout. I think the fact that we have so many different categories, really based on maternal treatment, suggests how hard it is to diagnose congenital syphilis. And these scenarios lead directly to our evaluation. For proven or highly probable cases, the workup is extensive. CSF analysis, CBC, and other tests as clinically indicated, including long bone radiographs, chest x-rays, liver function test, neuroimaging, an opto exam, and auditory brainstem response. For the possible criteria, they recommend doing a LP with CSF analysis and complete blood count and differential and long bone radiographs, and no evaluation is recommended for the less likely or unlikely criteria. For treatment, for those who are proven or probable, it's IV penicillin for 10 days. For the possible criteria is where it gets really interesting. There are 2 options. The first option is IV penicillin for 10 days. The second option is a single dose of IM benzazine penicillin G, 1 time. So many people ask, when can we do 1 dose versus when can we do when do we need to do the 10 days of therapy? Because most people would clearly prefer the single dose therapy. Here, you need to do the complete evaluation, including the lumbar puncture. And if the workup is interpretable, meaning you have a good lumbar puncture that's not contaminated with blood, the rest of the workup is normal and follow-up can be obtained, you can do a single dose of benzazine penicillin G. Less likely criteria involves a single dose of benzazine penicillin G or no treatment with close follow-up. And I can say that in clinical practice, most providers recommend the single dose therapy in this case. And in unlikely criteria, no treatment is recommended. In terms of neonatal follow-up, for neonates with a positive non-treponemal test at birth, repeat testing every 3 months is recommended until it's negative. In patients not treated at birth, it should be non-reactive by 6 months. If reactive, consider treatment. In patients treated at birth, it should be non-reactive by 12 months. And if reactive, consider an LP and 10-day course of IV penicillin. For neonates with a negative non-treponemal test at birth, but mom is positive, we should repeat the non-treponemal testing at 3 months to make sure we're not in the window period. 12 months after delivery, we did see Jack and Jill together for routine STI testing. They reported no sexual activity with each other except with each other since the baby was born. Jack's RPR was down to 1 to 4. Jill's RPR was undiluted or 1 to 1. And the baby had a negative or non-reactive RPR, indicating all were successfully treated. But we're not done yet. One door closes and another opens, and Jim is back. Jim was lost to follow-up after his hospital stay due to work and life disruptions. He finally returned to clinic 6 months later for a check-in, and his RPR titer was 1 to 128 when it was previously 1 to 256. So this is a twofold drop. So is this a non-response? So let's talk quickly about how we manage non-response. And this is a slide donated to me by the amazing Khalil Ghanem from Hopkins. Want to make sure he gets credit for this. But the first thing we should think about, are there any neuroocular otic signs or symptoms? If yes, we treat with penicillin. If no, the question is, did we wait long enough for titers to decline? Remember that in primary and secondary syphilis, we expect the fourfold decrease within 12 months. For early latent syphilis, we expect the fourfold decrease in 12 months. For late latent or unknown duration, we expect the fourfold decrease in up to 24 months. And then people living with HIV, it may take longer. If we haven't waited long enough, we should just wait longer. Did the patient get reinfected, or is the patient pregnant? These are important things to consider. If the patient may have gotten reinfected, we can retreat with a dose of BPG. And if the patient is pregnant, we tend to err on the side of caution and also consider additional treatment. Do they have a high titer? If the titer is high, we can consider doing a lumbar puncture. On the other hand, if the titer is low and less than 1 to 64, we should just keep following the titers. There really is no benefit to additional treatment. All of us in the ID world have seen patients get treated over and over again in hopes that the titers would go down, and sometimes they just don't. So I always tell people that if you're going to treat people, treat them one more time, but don't treat them over and over again, because there's no evidence of benefit in that, and treatment is incredibly painful for patients. In the case of Jim, his 12-month RPR was 1 to 38, showing that greater than fourfold decline or an appropriate response. Before we wrap up today, I do want to talk just briefly about how we can prevent syphilis in our patients. And really, it's the same way we prevent it for any sexually transmitted infection. This is my version of the STI prevention landscape, which also applies to syphilis, and talks about primary prevention, focusing on preventing disease before it occurs by reducing exposures, as well as secondary prevention, emphasizing early detection and intervention to prevent disease progression and transmission. And I'm going to focus on just one new method from that slide, which is medication prophylaxis with doxypep. For those who may not be familiar, doxypep is doxycycline 200 milligrams by mouth, up to 72 hours after a condomless sexual encounter at any anatomic site. And several randomized controlled trials have shown that doxypep can significantly reduce syphilis incidence in men who have sex with men and transgender women on PrEP or living with HIV. The IPERGATE trial showed a 73% relative risk reduction, doxypep an 80% relative risk reduction, and doxyvac a 79% relative risk reduction in syphilis infections. All three of those trials were in men who have sex with men and transgender women. The one study in females taking PrEP, the DPEP study, did not show a reduction in syphilis incidence. So far, the benefits for syphilis prevention are clear in men who have sex with men and transgender women, less clear in people assigned female at birth. And it's not just in clinical trials that we're seeing this. We're seeing this in the real world as well, with significant reductions in syphilis incidence in San Francisco, in the Kaiser Permanente health system, at a sexual health clinic in San Francisco, and in conference proceedings from Seattle and Boston. One of the things people always ask about are the theoretical risks of doxypep and the emergence of doxy-resistant syphilis. And that definitely is a concern, because it's one of the things that we use as an alternative regimen. And this 2025 study tried to directly test that possibility. Here they exposed a strain of Treponema pallidum both intermittently and continuously to low-dose doxycycline over several months, and looked for changes in growth, MIC, and genome. The result, there was no evidence that doxypep induced resistance in Treponema pallidum. So while we still need real-world surveillance, this study at least suggests that doxypep may not drive syphilis resistance, and is a reassuring signal for now. The only way we'll ever end the syphilis epidemic is through routine screening. And that means we need to screen at every opportunity, not just in STI clinics, but in emergency departments, urgent care centers, primary care visits, and of course, our HIV and ID clinics. Every encounter is a chance to diagnose syphilis before it progresses. And we've seen that in work out of an ED in Chicago, where they were able to increase screening from 3.6 to 24% of all ED visits. Presumed active syphilis infections increased 288%, and the number of females diagnosed with syphilis increased from 25 to 42%. They diagnosed 750% more cases of syphilis amongst pregnant people, and only 9% of people had STI-related symptoms, meaning they would not have been diagnosed otherwise. So if we want to be able to prevent syphilis, we need to make screening and treatment routine in all settings. And with that, we'll go back to our post-test questions. So this is our same question from earlier. A 32-year-old man presents to care with a single painless ulcer on the ventral shaft of the penis. He does not have a prior rapid plasma reagent test result, and he reports recent condomless sex with a new partner. Which of the following is the most appropriate treatment? And 90% got this answer correct, so we won't spend a lot of time on the answer. But that's right, he has a painless chancre that would be staged as primary syphilis, and so one dose would be correct. We did have 3% of people saying 3 doses, but that's used for late latent syphilis or syphilis of unknown duration, not for primary syphilis. And again, regardless of prior RPR testing, if you have symptoms of primary or secondary syphilis, we treat for that. Our next post-test question. All right, so we do have some mixed results on this one. Uh, for B, we have 28% that said B and 68% that said C. For B, it's doxypep has been shown to reduce syphilis infections among men who have sex with women and women who have sex with men in clinical trials. It's that second part that makes answer B incorrect. Remember, in the DPEP study in Kenya, it did not show benefit in women who have sex with men. C is the correct answer in this case, in that doxypep reduces syphilis incidence, particularly in men who have sex with men and transgender women, and at least as we've seen so far, not been associated with increased resistance in the lab or in the real world. And with that, I will stop and turn it over to Connie or Dr. Celum to lead our Q&A session.
Well, Jason, that was, or Dr. Zucker, that was fantastic. I want you to recognize you have as many accolades as questions, which I think is really a statement. And I have been thinking about people I will forward this to because I think it's great. So I'm just going to quickly run through the questions that I've seen in the Q&A, and then maybe we can get to some that were submitted ahead of time. Let's see. Someone, actually Sue Blank from New York, asked about Jim's LFTs and how quickly they return to normal.
Yeah.
And his renal function.
Yeah, so LFTs generally return to normal relatively quickly, and actually his were normalized in under a week. But when you look at the graph, his actually started trending down almost immediately after treatment. I was trying to find in the literature the expected time course for resolution of renal dysfunction, and it was a little hard to find. In his case, it actually peaked after treatment, improved, but never came back to his baseline. So a little unclear whether it will take longer and we'll eventually get there, or we will have some ongoing renal complications from this.
Great. Fantastic. And someone else, Michael Lim, Dr. Lim, asked about Jack, the case, and since he was on PrEP, did you test for Hep B and C?
Yeah, so he's been tested for Hep B and C before. The current recommendations are annual screening for hepatitis C, and he was screened for Hep B at initiation into our program. And so he wasn't necessarily due for his Hep C screening at the time of that visit.
Great. And then let's see, there was maybe I'm going to come back to doxypep because there were a couple of questions submitted in advance and then one in the Q&A today about whether doxypep affects the RPR changes, either slower rise and or decline after treatment.
That is a hard question. I think one that we're all worried about a little bit. We've seen in the HIV literature that rapid starts can lead to either seroreversion or slower production or slower progression to antibody formation. It's harder to see that in the doxypep literature in large part because of that long incubation period and because we don't have another type of test we can use as the gold standard for validation. There have been a few case reports published so far that may suggest that. I think it's something that we're all looking at and all concerned about, but I just don't have good evidence for you about that so far.
Yeah. And then another question from An about treatment of contacts of pregnant women with syphilis. Would you recommend 1 or 2 shots of bicillin?
For the partners,
Yeah, well, I think that.
so the partner should only need one dose for treatment. The exception to that is that if they fall into the late latent category, so they should be given one empiric dose, but then they should also be tested. If they fall into the late latent or the latent of unknown duration category, they really should get 3 doses, 1 dose weekly for 3 weeks.
Okay. And then Beth Godowski asked about a case of progressive hearing loss. I'm not sure if it was unilateral or bilateral over a 30-year time period in an older patient who had a prior history of syphilis about 20 years ago who was treated. And the ENT doc wondered whether this could be due to syphilis. How would you respond?
Yeah, syphilis in elderly patients is just so challenging, especially when you can't get a great history about sort of what testing and treatment they've had in the past. One of the many challenges with our current diagnostics is that the RPR will actually go down over time. And so you may see someone with a very low RPR after decades, and that may not necessarily not indicate that they don't have syphilis. If there's a serious concern about that being the cause of the hearing issues, I'll do one of 2 things. You can do a lumbar puncture to look for a CSF EDRL. It will only be positive about 40% of the time, even if they have otic or optosyphilis. And so in my thinking, it's either you're going to do the LP and only treat them if they're positive, or if you think you're going to treat them either way to take that off the table as a potential cause, then just treat them and don't put them through the lumbar puncture. And we've done that numerous times when neuro or opto has really suggested that they felt that this person may have neurosyphilis or otic or optic syphilis. Doing the LP in those cases is not necessarily diagnostic, and so we'll just treat them empirically, see if they
Mhm.
improve, and take that off the table as a potential diagnosis.
Can you comment on whether it's helpful if the hearing loss is bilateral or unilateral? Does that weigh in your thinking about
Yeah,
it?
not at all. You can see either of those in otic syphilis. And so it can be unilateral, it can be bilateral, it can be rapidly progressive, it can be slowly progressive. So it doesn't really help.
Okay. Then Mark Bihar asked about if probenecid is not available, could cobicistat be used to delay renal excretion? I think this is related to neurosyphilis and procaine pen, but maybe you can expand on that. Like, is there any role for using uh, cobicistat with any other alternative? Would you feel?
I would have to look. I've never seen anything in the literature, but I can't comment. But they also work very differently. Like probenecid is reducing renal excretion, while cobicistat is reducing liver error, well, involving the liver and degradation. And so they have different mechanisms of action. I don't know what it would do, to be honest.
Okay, I think that's fair. Um, Let's see, Tashina Spears asked about what your thoughts are about a pregnant woman with syphilis who's at least more than 40, sorry, more than 24 weeks of gestation. Would you recommend to give benzathine penicillin in the hospital? I think this is basically to document that they have treatment, and I assume maybe also to make sure they don't have a Jarre-Herxheimer reaction.
Yeah, so the in the old in previous generations, they would actually want to treat them in the hospital because they were concerned about the Jarre-Herxheimer reaction. There was a paper that came out that I didn't include in today's talk that actually looked at that, and there's no increase in preterm labor from the Jarre-Herxheimer reaction. So there's really no reason to admit them for treatment if that's what the question's about.
Okay. And then let's see, there are a couple recent questions. Do you want to comment? Someone, Laura Beauchamp said, I have some questions about doxypep and doxyprep in women. Do you have hope that some studies will be funded given?
I think this is a question for you.
I do. Well, for those who follow the doxypep and doxyprep field, there was a study that was poised to get started through the Adolescent Trials Network, which was then terminated but has been reinstated. And I think this is one of their top priorities. So yes, I have hope. Um, let's see. Then someone said, such a tough diagnosis of otoxyphilus. So true. We have seen ENT just rule out other structural things with MRI, but no definitive tests. I suppose anything is possible or could be otoxyphilus, they said. Want to comment on that?
Um, Yeah, I mean, we were talking earlier, but we've all been fooled by syphilis many times. The more you do this, right when you think you know everything, you see a case that's different than anything you've seen before. Syphilis is a really challenging diagnosis that's being made more and more frequently as we see more and more cases. And we need to have a high index of suspicion. If you think that patient with otic symptoms has syphilis, we should do an RPR and we should consider treatment. The, the benefits of treatment could be hearing saving, so it's huge.
Yeah. Well, speaking of that, can I ask you a case that I saw?
Sure.
Okay, so I saw someone, classic situation. I was talking to one of my patients who's been a little hard to follow and now even harder, but living with HIV for at least a decade, had a new positive RPR, and at the time I only knew it was positive. I didn't have the titer back. Turns out it was 1 to 256. And as I'm putting my hand on the doorknob to say, well, I'll see, anything else you want to say? Tell me about this. And we were planning to treat him just as, start off with one bicillin shot. He goes, well, by the way, I have a curtain falling across my visual field in one eye. So we got him in for slit lamp exam, and he had both a detached retina partially and some uveitis. So we got him at that. This was let's see, 2023. So we did use procaine pen and probenecid, and he later said he didn't take the probenecid. But his titer remained at 1 to 256. So we're now out at 2 years. We're trying to get him back. If it is 1 to 256 and he didn't decline, but he says his vision is better, what would you do? Would you do an LP at this point and go for IV penicillin G?
I think I probably would. That's a persistent high titer,
No.
and that one should be worked up, which I treat very differently than a persistent low titer, even if it didn't decrease fourfold. I think if the titer is really 256 and it's been 2 years, it's probably worthwhile to either do the LP or once again, if you think regardless of the LP you're going to treat, you could just start treatment. And we do that a lot here because they're patients, the diagnosis of neurosyphilis is really challenging. You can have neurosyphilis with a completely bland CSF profile. You don't necessarily have to have a positive one. And so patients that we're convinced have neurosyphilis, we're probably better off treating than even doing the diagnostic test. The diagnostic test is really more helpful for ruling out other causes than syphilis.
Okay. And then one other question, just if you permit me to ask one of my questions. I haven't seen it, but maybe I've missed it. Among these almost 4,000 cases of congenital syphilis and more than that in prior, and similar numbers in prior years, what are the stages of syphilis among the mums? Has that been summarized, off the top of your head?
I don't remember the exact date. The vast majority are early though. So it can be early latent, but the vast majority are early syphilis. So primary, secondary, early latent.
Mhm.
There is some late latent for sure, but I don't off the top of my head remember them. But it is in the article.
Okay.
Yep.
Well, I think we've gone through all the questions. I apologize if I've missed any. Someone asked about, is there any hope for a syphilis vaccine?
I hope so. I mean, there's been syphilis vaccines that have been studied and that were in the works. Obviously, everything with vaccines right now are up in the air, but I hope that one day we'll have one. It would be game changing. I mean, obviously, we're seeing more and more cases of syphilis and congenital syphilis, and a vaccine would allow us to prevent those cases. And so I hope we do one day.
Okay. Well, there are many people, again, thanking you for a fantastic presentation, the clearest they've seen. You should read the comments. They're really glowing, and appreciate you making the slides and IAS-USA making the webinar available. It's a real resource, and I think you have a career ahead of you of educating us all about syphilis. Yeah. So before people drop off, we want to just end up and first of all, thank you again from everyone on the call, Jason. And here's the information about how to claim CME and pharmacy, nursing, pharmacotherapy credits. You'll get it by email tomorrow. Please give us feedback and a few highlights of things to stay tuned for, that there will be a future webinar, or sorry, it's a new podcast, wrong. Podcast, not webinar, about how vaccines get approved in the US, highlighting the story about RSV and the role of the ACIP with Dr. Yvonne Maldonado. And for those like myself who need to learn a lot more about bacteriophages, which have interesting history and now clinical applications, be aware that on June 30th from 10 to 11:15, Graham Hatfull and Chip Schooley will be talking about this, and it's a very interesting area. And then on Thursday, September 25th, there will be a webinar on HIV 101, Foundations of Management of People Who Are Newly Diagnosed with HIV with Mike Sag, Carolyn Chu, and Trip Gulick. And I think this is the last one. There will be a conference on bacteriophages in person, apparently, in Washington, D.C. at the Washington Hilton on October 12th to 14th. And those are the dates for submissions for registration and abstracts. And then just really want to thank you all for joining and for your great questions, your positive feedback, and your interest in syphilis. Thank you. And please share the link to the webinar widely, because many people could benefit from, I think, your really clear and comprehensive presentation, Jason. Thank you again.
Thank you, everybody, for coming.
Thanks. Bye.